Welcome, everyone. Thank you for joining us this afternoon. My name is Nick Bradnicki, and I'm the Executive Director at the American Heart Association in Oregon and Southwest Washington. American Heart Association and OHSU joined forces with the goal to reduce cardiovascular death, heart attack, stroke, and heart failure in our communities. Now, as always, on these virtual events, a couple of housekeeping items before we begin. Today's discussion is a webinar format, and even though we can't see you, we want to hear from you. We will have time at the end of the program for audience Q&A, so please put your questions in the chat box. And as always, make sure to choose everyone from the drop-down menu. That way, all of us can engage together in those questions. Now, it is my pleasure to introduce Anthony Mulholland, the Senior Director for Heart and Vascular Services at OHSU Health. His tenure at OHSU has spanned 19 years, where he has held progressive leadership positions, including CV ICU charge nurse, nursing administrator on duty, nurse manager of cardiovascular intermediate care and telemetry, and Director of Cardiovascular Services. And Anthony's community leadership also includes his role as a board member of our regional American Heart Association Board of Directors. Welcome, Anthony.
Hey, thank you, Nick. Good afternoon, everyone, and thank you for joining us at our heart failure workshop in collaboration with the American Heart Association. Please let me start by thanking my team at OHSU and Mariah with Care Oregon, who are providing the content for today's event. And I also want to thank our friends at the American Heart Association who work tirelessly to improve heart and brain health for everyone. I'll share a brief history of the genesis of the creation of these workshops. OHSU and the American Heart Association made a commitment to join together a little over 4 years ago to address heart failure. Through our partnership, we've distributed patient information materials on heart failure. We've developed a heart failure online hub, which is where this recording will be shared later. And we've produced these education series that rotate, reaching those living with heart failure and their families who support them, and sessions tailored to educate healthcare providers. Some of you have attended some of our previous sessions, and we welcome you back. Thanks for being here. This month, not only are we celebrating National Heart Month, but we're also honoring Black History Month. As this group was developing this program, we wanted to bring a relevant topic and today our program will focus on racial disparities in heart failure care and how to mitigate those disparities in your practice. We'll hear from 2 incredible speakers and close with a panel discussion on best practices and strategies. So I'll start off with a great big thank you for joining us and introduce you to our first speaker, Dr. Albert Camacho. Dr. Camacho specializes in the early diagnosis and treatment of heart failure. His research includes clinical trials to develop new devices and medications for heart failure. And according to Dr. Camacho, understanding a patient's individual needs is essential to treating heart failure. Creating personalized treatment plans is one of the most satisfying parts of his work. Dr. Camacho also works with a team focused on effectively treating patients in the hospital. And this includes finding ways to keep people with heart failure from having to come back to the hospital after treatment. Medical education is another important part of Dr. Camacho's work, and he teaches medical students in the classroom and in the OHSU clinics. Finally, he's involved in the cardiology fellowship program, the final stage in the training of future cardiologists. Welcome, Dr. Camacho.
Thank you, Anthony, and thank you to the American Heart Association for inviting me to speak at this webinar. I've had the privilege to have been involved with the American Heart Association since they granted my first grant that helped me get a cardiology fellowship at UC San Francisco. So the AHA will always have it be near and dear to my heart. I think it's important to start with some definitions if we're talking about racial disparities in healthcare. And the first one is, what is not race and what is race? This is taken from an excellent document put out by the American Heart Association last year, but it's very similar to other definitions that you'll find. First of all, it's important to understand that race is not rooted in biology and is a poor surrogate for biology. And I believe in the as healthcare providers and also in medical science, this is all too often forgotten. Race is a social construct without clear definitions. To use some examples, what's the difference between African Americans versus Black people versus Blacks? It really depends on who you ask. Many workers in this field would say that African American primarily identifies people in the United States who are descendants of slaves. Black people is a more general term that can include folks who came as immigrants from Africa or other parts of the world. The bottom line is that self-identification is most reliable and appropriate. What about ethnicity, since oftentimes we talk about race and ethnicity? Ethnicity is also a social construct referring to cultural identification, and that includes things like language, music, sometimes country of origin, but often region of origin. Again, self-identification is most reliable and appropriate. This slide shows you data on heart failure-related death rates, comparing Black men and women with white men and women between the years 1999 and 2017. A couple of things to point out. As someone who works in heart failure, I'm saddened to see that we really haven't reduced death rates in younger adults aged 35 to 64 during this time span. For the purposes of this talk, I'd like you to focus on the fact that there are significant differences in death rates between Black men and white men, approximately a 2.6-fold greater death rate among Black men. Between white men and between Black women and white women, the difference is quite similar, and it's about a 3-fold difference. If you look on the right panel, this provides the data for older adults, age 65 to 84. And here the differences might seem different, but notice that the scale is much different because death rates are much higher among older adults. So the actual numbers in terms of actual number differences between these two races is really very significant. This slide shows heart failure hospitalizations between 2002 and 2013. And this is crude hospitalization rates comparing Black men and Black women with white men and white women, Hispanics and Asians. And again, here you can see a stark difference between Black, whites, Hispanics, and Asian, and those of Pacific origin. And we really haven't made much of a dent in terms of reducing the difference between these two groups. So where do we start in terms of trying to address these disparities? An important place to start is in social determinants of health. And I will just introduce this concept because our next speaker, Lauren Suarez, will go into more detail. But for our purposes, I'd like to point out that in terms of healthcare, access and quality, those of us that are directly involved in this is only one aspect, and the other ones are at least equally important. So I believe this also gives us the responsibility as healthcare providers to also speak to issues that are not directly related to healthcare. This slide shows factors that influence heart failure disparities. Starting on the left, you can see again how the neighborhood environment and other social elements play a significant role, especially impacting traditional risk factors like obesity, diabetes, and physical inactivity. There are also some interesting differences in terms of broad generalities in terms of some physiologic differences that may be important in terms of choosing medical therapies. But I'd like to focus more on the right panel, where we focus on healthcare system and policy, and especially the things that we as providers can impact, including clinician access, implicit bias that I'll talk about more, how to apply guideline-directed medical therapy, and workforce diversity. This slide shows, I really like this slide because it's quite detailed in terms of identifying targets for reducing healthcare disparities. And again, you can see at different levels from public policy, the community, our individual organizations, our interpersonal relationships, and very important, what we do as individuals. Those are all places where we can work on reducing healthcare disparities. I won't go into detail in these, but I hope you'll take the time to look over them. I would like to focus on one issue that really impacts our organizations and beyond, and that is the concept of structural racism. This is the ways in which societies foster racial discrimination through inequitable systems that in turn reinforce discriminatory beliefs, values, and distribution of resources. Structural racism adversely affects health outcomes, and these inequitable systems include those in housing, healthcare, education, employment, and earnings, as well as criminal justice. And it's really important that those of us that are leaders in institutions really focus on where this structural racism might appear, because it may not be very explicit, and unless we focus on it, we may not identify these features in our individual organizations. What about, can we provide an example of structural racism in medicine? And here I'm not trying to criticize any specific institution, just provide an example. And I wish it had been more difficult to find examples, but they're really not that uncommon. This example involves a podcast provided by the JAMA Network in 2021, where two white editors of JAMA questioned whether structural racism exists in medicine. Important to point out that neither are experts in the field, and they did not invite experts in the field to the podcast. And one of the leaders of the podcast, Dr. Livingston, who was then JAMA's deputy editor for clinical content, questioned whether racism could be embedded in a society because it is, quotes, illegal, end quotes. At that time, JAMA editors were overwhelmingly white and male. And the controversy surrounding this podcast led to the resignation of the editor-in-chief at the time. I'm pleased to say that JAMA has made some real important changes in the structure of their leadership, including in editors, but there's still a lot to do in terms of promoting diversity in our medical organizations as it relates to both to race, ethnicity, and gender identification. On a more personal level, I really think it's important to consider implicit or unconscious bias. This is prejudice or judgments in favor or against a person or group that we form outside of our own conscious awareness. The key point is that we need to question our judgments in order to bring the biases into our consciousness. I recently had an example of this with one of my African-American patients who lives in Eastern Oregon. For a variety of reasons, I wondered whether as his heart failure progressed and we needed to increase the complexity of his therapy, I really wondered whether he would be able to do it. But the more I started working with him, I saw that he is a very intelligent man who is very organized and was able to follow our instructions to the letter. And after our last visit, which was just a couple of weeks ago, I really stopped and thought, wow, I really had him judged wrong. And I had to face the reality that part of that was that he was African American, he was a blue collar worker, and those elements affected my judgment. The important point is that having unconscious biases does not imply a moral or ethical deficiency. In fact, some experts argue that unconscious biases have their root in tribalism that was essential for human survival. And with that, I'd like to close and introduce our next speaker, who is Lauren Suarez, who will further explore the social determinants of health and how it relates to your practice. Lauren is a licensed clinical social worker in the state of Oregon and Washington with a level 2 certification as an alcohol and drug counselor. She received her MSW from Portland State in 2016, and her career has been spent engaged in community-based clinical outreach and case management, focusing on marginalized and oppressed populations.
Thank you, Albert. So I'm going to continue our talk moving forward and expanding a little more on social determinants of health. Our learning objectives for today will be to discuss a brief overview of social determinants of health and how to add this framework to your practice. I'll articulate how social determinants can impact patient outcomes and identify and implement strategies to build equity and mitigate social determinants of health in heart failure patients. When I started doing some of my research for this presentation, I came across this quote, and it really resonated for me. And I think I would like to invite you all to sort of keep this in your mind as we kind of progress forward through the presentations. And it's every disease has two causes. The first is pathophysiological, and the second is political. So I'm going to reintroduce this graphic here on social determinants of health. Dr. Camacho had it earlier in his presentation. You know, I think, as you noted here, like there are some particular areas that there are some areas of social determinants of health. This is not all of them that kind of conceptualize what we're going to be discussing moving forward. So again, the education, access to education, the quality of education, healthcare access and quality, economic stability, your physical location, your neighborhood, the environment your neighborhood was built on, and the social and community contexts. I think what's important to note from this diagram, however, is what's not pictured, which is the political context, such as government and policy and cultural norms, and the values that make up the structural determinants of health. So social determinants of health are factors outside of traditional healthcare setting that impact an individual's life. They are the factors that are part of the fabric of our lives that we are often don't consider interplaying in our health. There are non-medical and non-physiological aspects to an individual's health. Additional examples of that include the home, family, community, social environment, economic circumstances, food insecurity, housing, transportation, employment, education, and health literacy. They are health factors that are interconnected and interdependent on the ecological system that comprises a person's life. As a reminder, every disease has two causes. So we can't discuss social determinants of health without further considering, again, systemic racism and implicit bias. There is a historic and inherent inequity and injustice in our healthcare system. If we look at the perspective of socio-epidemiology, we can see the efforts of social structures on health, and we can begin to explore and understand how the consequences of colonialization, forced migration, racism, poverty, and how social structures and institutions shape and influence health. Social determinants of health, systemic racism, and implicit bias play a large role in health outcomes. It is critical as healthcare workers that we recognize the impact disparities such as race and ethnicity have on our health outcomes. Many health disparities can be seen in the prevalence of heart failure rates in Black patients compared to white patients with higher risk of poor clinical outcomes. Black patients have the highest incidence and prevalence of heart failure, as well as the worst clinical outcomes. While heart failure is expected to affect almost 3% of Americans by the year 2030, Black patients will carry the highest burden of disease with an expected prevalence of 3.6%. African American patients have the highest risk of heart failure-related deaths. So how do we create a change and move from a place of implicit bias to a place of health equity? Our healthcare systems are beginning to understand how these factors influence and impact health outcomes and are engaging in interventions aimed at addressing social determinants of health. One example of this is regular screenings for social determinants of health. But more importantly, what's needed is a change in culture, a stronger recognition of the dignity and self-worth of our patients. Health equity isn't just a matter of increasing screenings. It's exploring how oppression breeds distrust with our medical system and impacts provider and patient relationships and creates barriers to care that is the root cause of health inequity. Social determinants of health and heart failure, and we see an increase in number of patients with heart failure who experience barriers to fully engaging in care. Many of these patients are houseless or housing insecure. Many experience a number of psychosocial barriers to engagement, such as mental illness and substance use disorders. Healthcare professionals must recognize and engage the environmental factors that may be negatively impacting a patient's ability to engage in care and adopt a healthy lifestyle change. So what are some strategies that we can build on to build more equity? Health equity requires organization and clinician buy-in. It requires a willingness to adapt shared practice, philosophy, and clinical values. As clinicians, you can help mitigate social determinants of health in heart failure patients by engaging in a changed mindset when working with these patients. Additional strategies that we can adapt include education and training, such as implementing a recovery and resiliency model of care, a greater focus on personal goals and strengths rather than on illness, engagement in trauma-informed care training and practice adaptation, a recognition, acknowledgement, and accountability to our own internalized biases, a willingness to engage in discourse with both our colleagues and our patients, and bringing healthcare professionals together to explore system barriers and build better understanding and partnership, adapting health policies that can help share practices such as social determinants of health screenings. These strategies require a changed perspective. In medicine, we seek to treat the disease and not the person. The inclusion of social determinants of health offers us an opportunity to shift our perspective from disease-focused management to patient-centered care, a whole patient perspective to intervention and care. Understanding a patient's story is part of the course of treatment. And I think now I'll pass it back on to Anthony so that he can introduce our panel discussion. Thank you so much.
Yeah, thank you so much, Laura and Dr. Camacho. Wow. Thanks for sharing your moving presentations. I know I learned so much today about racial inequities and ways that I can improve my own practice now that I have deeper awareness of the frameworks you shared today. And I was particularly impressed by the background of structural racism in medicine that you presented, Dr. Camacho, and then the adaptable strategies you just shared with us, Laura. So thank you so much. It was a real gift to receive that from you today. So joining us now for our panel discussion on best practices will be, bear with me here, I'm going to do a host of different introductions. We've got joining us Jane Mitchell, Mariah Alford, Jesse Dunn, Karen Epstein, and Nathan Samuel. Jane Mitchell is a nurse practitioner and instructor of medicine at the Division of Cardiovascular Medicine at OHSU, and she's been a nurse practitioner since 1979. And she's been a nurse since 79 and a nurse practitioner since 93. She specializes in the care of heart failure patients, specifically transitional care and patient outcomes. Mariah Alford is the Senior Pharmacy Manager for Clinical Services at Care Oregon. She's a clinical pharmacist by training with over 10 years of experience supporting the needs of patients. And currently, Mariah manages a team of pharmacists that supports safe care transitions for dual eligible Medicare and Medicaid patients. Wow, important work. Jessie Dunn is a clinical pharmacy specialist working at the OHSU Knight Cardiovascular Institute, and she has 17 years as a clinical pharmacist, where she's worked in 5 academic centers and a variety of cardiac roles. In her current position, she supports the advanced heart failure and transplant clinics at OHSU. In addition to her clinic role, she's involved in teaching pharmacy students in the OHSU OSU College of Pharmacy, as well as training pharmacy residents at OHSU. Karen Epstein is a physician assistant and part of the advanced heart failure transplant inpatient team at OHSU. She was born and raised in Long Beach, California, where my nursing school alma mater is. She relocated to Portland 2 years ago after 17 years in New York City. Prior to studying medicine, she worked at Memorial Sloan Kettering Cancer Center, where she led patient-centered quality improvement initiatives and developed and managed the Patient and Family Advisory Council. She also studied public health with a specific interest in addressing health literacy as a social determinant of health. And finally, Nathan Samuel is a nurse practitioner who specializes in the care of patients with advanced heart failure and heart transplantation. After working as a registered nurse in Eureka, California, he moved to Portland in 2015, where I hired him as a nurse in the cardiovascular step-down unit at OHSU. His experiences working with patients living with heart failure inspired his path to becoming a nurse practitioner and led him to complete a doctoral research project aimed at identifying ways to help patients with heart failure avoid rehospitalizations. Okay, that's everyone. And welcome back, of course, Dr. Camacho and Laura. We have some prepared questions for our panelists, but we also want to hear your questions. So please remember to click everyone from the drop-down menu when typing your questions and putting them in the chat. So I'll start with our first question. Mariah, this one is for you. Can you tell us a little bit about what resources Oregon Medicaid insurers like Care Oregon are able to provide to patients related to social determinants of health barriers?
Thanks, Anthony. There's a ton of different services that we are able to help connect members to, and all Medicaid plans in Oregon are providing very similar benefits. But language access services, we can coordinate those. We have housing case management to help you connect members to us for expertise in getting housing. Health-related services funding, which are providing funding for services that are not covered by Oregon Medicaid traditionally. So that can be related to all sorts of different things from tarps and things to help people that are houseless, to providing basic supplies for personal hygiene to members, transportation benefits. We can help coordinate rides for members to and from appointments. All of that is coordinated through our care coordination team, and I can just provide the phone number for everybody, but all of this is also available on our websites under the provider support pages. But if anybody needs it, our direct case management phone number is 503-416-4100, which is our direct number, option 3. We're always happy to help address any member issues that you need support with.
Great. Thank you so much, Mariah. And did you want to provide us with the website as well?
Yeah, so careoregon.org /providers/support.
Wonderful. Thank you. Those are great resources for all of us. Okay, let's move to our second question. This one is for Karen, one of our inpatient providers at OHSU. Karen, how do you approach treating non-English speakers, and how can we help mitigate some disparities that might exist there?
A great question, Anthony. I've often found that non-English speakers or patients with limited English proficiency will tell us that they're okay without an interpreter, or that they can get by, or it's fine, we don't have to go through the trouble. This is especially true, I think, when patients feel intimidated by the healthcare system, or are self-conscious of their limited English or lack of formal education or limited health literacy, or even their documentation or insurance status. If you have any question or doubt about someone's ability to fully understand and participate in their care, be it a simple physical exam or a more complex care discussion, it's always best to use a medical interpreter. I found that I get more and more accurate details from the patient when using an in-person interpreter as compared to video or phone interpreter, although of course we have to work with what we have often. So I always prefer in person if I have that available to me. Sometimes, although not always, having an in-person interpreter allows the patient to feel more comfortable sharing and more understood from a cultural standpoint. I've had that experience a few times. And it is an absolute must to have an interpreter when discussing anything around big medical decisions, end of life, advanced care planning, and certainly for consent for procedures or clinical trials. These are non-negotiable. You must have an interpreter. And just a reminder that family members and even staff who may be fluent in the language but aren't certified medical interpreters should not be used as interpreters unless there is absolutely no other option. Even if the patient asks a family member to translate, it's always best to say, you know, I appreciate that, but it's best for so-and-so, your mom, your brother, your son, to be there for you right now to help you understand and ask questions, and we'll let a translator do the translating. And if it's not documented in the patient's chart that the patient needs a Spanish or Cantonese or whatever language interpreter, please document this. Document it wherever you can, in referrals, in notes to schedulers, wherever. It will help with planning and can save you from tracking down interpreter services at the last minute or from failing to have an interpreter there at all. At OHSU, at least on the inpatient side, we can actually schedule interpreters to come to the bedside, so we can often coordinate them with our rounds so that they're there at a specified time every day, and we know that we'll have them as a resource. So if you're in an inpatient setting, I certainly recommend looking into that possibility.
Great, thank you, Karen. Wow, those are great recommendations and also great reminders for many of us. And I want to invite the panelists who are with us today as well to feel free to hop in if there's anything that you'd like to add to anything to build on any of the responses from the panelists. Okay.
I work in a clinic setting, and to build off what Karen said, I think it's super important to also build in structure to make this a more meaningful experience. It's different than a regular conversation. There's a third person involved in the back and forth. So building structure into those visits so that you have that extra time, because if you're going to do it right, it's going to take the extra time. If you're learning about medications when I'm counseling, patients will have the questions, and it takes about twice as long to conduct this properly, to make sure that you really do answer all their questions. So if you know that that's a need, build that structure into your clinic day, so you're not rushing the patient, so you're not cutting them short, so you're not making them feel like they're unimportant.
Well, I think too, it's not just it's labor intensive at the beginning, but that will save you so much time down the road.
I have one more thing to add. Oh, I've noticed when using, or I've always thought about when using an interpreter, still using patient-centered language, even though you're speaking through an interpreter. I think sometimes, you know, you can think, oh, I'm speaking through an interpreter, they'll make it so the patient can understand. But if you're still using jargon, even the interpreter, they're not going to necessarily convert that to patient-friendly language.
I would just quickly point out that in terms of building rapport, it's important not to make assumptions. For example, to assume that someone from a Mexican origin speaks Spanish. They may in fact be an indigenous person whose Spanish is quite limited, especially if it's an older individual. And so to keep that in mind, but it's also true not to assume that the patient speaks Chinese. What is that? I mean, there are thousands, I believe, of languages in China. Taiwanese is different. Also, never a good thing if you assume that someone speaks Russian when they really want you to speak Ukrainian, especially these days, but that's always been the case. But again, it's making it patient-centered and allow patients to self-identify themselves.
Great. Really great discussion. Thank you, everyone. And those are all important points. I want to just call one comment out that was left in the chat for us. And this is related to Mariah's comments. Care Oregon also has RNs and social workers that can work with patients in their home. So just wanted to put that shout out there so that we all had a chance to hear that. So our next question, I'm going to tee this one up to Nathan. Nathan, how do you think racial disparities and unconscious or implicit bias can affect the provision of advanced heart failure therapies? And are there any strategies for addressing potential inequities related to these therapies?
Yeah, I think that, well, I know there's registry data to suggest that there is inequity in the provision of these therapies to Black patients compared to white patients. So we know this is true. I think it's important to recognize that when patients are considered for these therapies, it's a very complicated process, and it oftentimes can be. There's a lot of subjectivity to it by the nature of the process, just because it's so complicated. It's not just are they medically appropriate to receive the therapy, but socially and other factors. So I think it's really important to recognize the ways in which structural implicit bias, structural racism can affect how we think about considering patients for advanced therapies, and just making an effort to acknowledge these factors when patients are being considered. And one other point I just would like to make in terms of that is that I think language really matters. The way that we speak, to our colleagues about patients, the way that we chart about patients can have a lot of bias. There's a lot of potential for bias in the language that we use. And I think that can potentially affect whether patients are considered for advanced heart failure therapies.
Great, thank you. Thank you so much, Nathan. I know that in the selection committees, the multidisciplinary selection committees for advanced therapies, there is careful consideration that's taken, and I've often witnessed the team checking themselves to ask if there are implicit biases or other kind of unconscious biases that they are not aware of. And it's really great to witness that back and forth dialogue. So glad to see that that's happening when those therapies are being considered. Okay, I think we have a question for all panelists. So let's see, how do you implement SDOH screenings? What type of questions do we need to make sure that we ask?
I work with medications a lot. Social determinants of health really affect medication therapy, which is a hallmark of the foundation of care of heart failure patients. And so I've gotten to the point where I ask the same set of questions to everybody. I have patients that will dress in their Sunday best, show up to clinic and look really fantastic, and they're really on the ball, and they'll say yes to everything you say, whether they understand it or not. So I've gotten to the point where I use very patient-centered language. I structure my notes exactly the same for everybody, regardless of who's sitting in front of me, and I ask the question every time. So I ask about medication affordability. I ask about copays. I run the copay checks myself sometimes just to see what they look like, and then ask those copay questions in clinic for them and say, hey, these costs add up. What do you think? We can do things about it. And I make sure that they know that it's a normal thing to complain about costs. It's a normal thing to complain about these things, so that they themselves never feel abnormal. And I just keep super structured every bit along the way.
Great recommendations. To the extent that we can standardize, we should, of course. How about others? Any other thoughts from the panel?
Well, I do a lot like Jesse does as well, but the first thing I do whenever I approach a new patient is I sit down, whether they're in the hospital or they're in the clinic, I sit down and I find out what their story is. So for me, by the time they're finished telling me their story, then I already know So now I can guide by asking these other questions, like, what do you think of this? And what do you think of that? But it really helps me. And then I write that. So every time I see that patient, I'm like, oh yeah, this is that person. So for me, that's super helpful.
Great,
And,
Jane.
and to build on that, one of the things I really encourage our trainees when they see a patient for the first time is to listen, to start by listening. And I understand our time is limited with patients. We believe we have a lot of information to pass on to them that indeed is important, but it's so important to listen first, number one, to what are the specific questions, concerns that patient has at that time. Even if it's not directly related to what I'm dealing with, I can empathize, point them in the right direction. And then as Jane says, the story, tell me a little bit about yourself. I'd like to know about my patients, things where they're from, what careers they had, life experiences, if they're immigrants. For example, patients from the former Soviet Union often have a significant distrust for the healthcare system. The same for our African American populations, with very good reason. And just understanding folks, I think, is really very helpful. And in my experience, ends up saving me time. Plus, it's a lot more fun. You get to know people, and that's what it's all about.
Indeed. Laura, is there anything missing from the social work perspective? We've been talking a lot about to our direct medical providers. What are we missing from social work?
No, I appreciate the comment both Jane and Albert made. And I think that absolutely it's important. And I think all of our responsibility is to, again, like as I was noting, sort of bring that humanness back in, make sure that in part of care that we're learning people's stories, right? Because that is so influential to understanding how they're engaging with the medical system, how we're able to be innovative or have to adapt around it. I think one of the things to think about, especially sort of working with, our maybe houseless population is the number of barriers that they are facing to just being able to do to meet their basic needs, let alone follow up right on their regular care. So I think again, when I was talking about sort of recognizing that resiliency model, are they showing up? What effort did it take for them to show up? Maybe they're not being able to engage in care and treatment in the way that would be ideal, in the way we would like. How can we adapt that, knowing sort of what we know about a story, in order to sort of support them so that they can engage in care as best as possible? And I think we also have a responsibility and an onus to supporting that aspect of care. We don't want to, knowing that our patients sort of come from so many different backgrounds, have so many different experiences, for our healthcare system, our political system, all of these things, right, that are informing and influencing care, that we're not re-traumatizing folks, that we are owning the part that we need to carry that forward. So we're not asking people to repeatedly tell their stories, that we are mindful about the ways that we are implementing screenings, so that we are ensuring that we're supporting patients as they access care, but we're not, again, doing harm to them by asking them to sort of highlight. These are very intricate personal areas of our lives, right, that we ask our patients to bring forward every time they come and experience care. And so I think those are aspects that we should be mindful of and take into consideration, and it is our responsibility as healthcare providers.
Thank you, Laura. Yeah, you touched on something that really resonates with me. I was having a really meaningful conversation with a provider in our clinic recently who was talking about patients not showing up. And what this provider was saying was, I don't really know what the lived perspective is for that patient. And so it's really important to me. We were talking about re-traumatizing patients, which is something else that you talked about. If we were to approach that patient, or the next time we see them, mention it, bring it up, make the patient feel uncomfortable about the fact that they weren't able to be there at their previous scheduled appointment, when we don't really have any frame of reference as to what barriers that patient was facing in order to try to even make it to that appointment, right?
Absolutely. And I think one thing I just will add that was touched upon too is when we have those experiences, how those experiences translate into how we document that into the chart, right? And how we tell that story. So really putting that emphasis again on how language matters. The terms that we use, medication non-adherent, when really truly it's not that they're not adhering, it's that it is truly an obstacle to try to get there. So I think having that information, keeping that out in the forefront of how we engage in care, and making sure that we have that as we sort of navigate and translate care so that it tells an appropriate story that is really helping to guide and inform care and is not creating further barriers and doing further harm to someone who is doing the best that they can to try to engage in treatment and care.
I wonder if any of our practitioners on the panel have a recommendation about a trauma-informed way to document medication, quote unquote, non-adherence. Is there a way that you
if I could, Anthony, give a quick anecdote building on what Nathan and Laura both said, and this is an actual experience in the last year when I was attending on the inpatient service. As you know, the attending usually is the last one to see the patient. So I was reviewing notes and there were, mention of medication non-adherence. The patient reported that they, and this truly was in quotes, lost their medications, or their medications were stolen, I believe is what it said. And so I went and started talking to the patient, and it was the most moving story where he explained to me how he was living in his car and he had to go find someplace to wash up and go to the bathroom. And then his car was left alone. And even though he tried to hide his bag, somebody broke into his bag and stole it. And I mean, listening to his story, I mean, on a certain level, I know this happens, but hearing it and understanding that this person had an ejection fraction of 35% and needed to be on a complex medical regimen, the resilience that patient was showing just to be alive at that time was truly humbling.
Yeah, very humbling. Talk about barriers. My gosh, thanks for sharing that, Albert. Okay, I want to ask another question, and this one is going to come to you, Jesse, as one of our pharmacists. Sometimes it's difficult to identify people who have social barriers limiting their care. Can you think about things that you can do in your own practice to easily identify those barriers in order to meet patients' needs?
So I am kind of lucky. I have access to a lot of different resources that allow me to do like preemptive screening, at least from my medication standpoint. But I go through and I make sure I ask all of the different questions before I even see that patient. Like I look through the chart, I try to think of what is the story I'm not seeing in the chart? Like Albert was alluding to, like it might say something in parentheses like medication non-adherence. And I think, well, what are the barriers to getting your meds? Getting the meds in your mouth is only 13% of a contribution to actually being adherent. There's cost barriers, there's prescribing hurdles, there's drug shortages, there's access to providers. We've been getting sick just as much as anybody else has been getting sick. And if they were due to be in clinic and somebody had to be out, then how is that patient supposed to be there to get the refills? So there's a myriad of different things that we need to look at in medication adherence. And I like to think of what are the list of the barriers? What are the things we need to do? And how do we break that down for the patient? So identifying up front things that have been reported in the past, digging into where the actual truth lies, and then figuring out how do we break down that barrier and make it more accessible to patients so that it works for their life. We're here to give them the medications that might make them feel better. We're not here to help them stay alive to take the meds we say they're supposed to. We're here to give them the things they need to live a better life. And so making sure that we do the things that we need to do from their reporting, from what they say is their hurdle to really having good care, that's where we need to meet our patients.
Great, Jesse. That's wonderful. And good recommendations.
If I could add that I have the privilege of lecturing a lot. And one of the things we emphasize is, for example, heart failure with reduced ejection fraction. There are now 4 classes of drugs that we want our patients to start in the hospital. The best ones needing twice daily dosing, specifically Entresto, for example. And so we really emphasize that to patients. But I also then turn around and tell our trainees, look at it from this patient's perspective. Is now the time when they're trying to deal with substance use disorder, with housing insecurity, food insecurity. You know, we can get to that. I know that ideally for most patients, we want to start it in the hospital, but what can this patient do? What are the highest priority medications taken once daily that will improve this person's quality of life? And actually, for most of them, it's not quality of life, it's just trying to make it through life. And in many cases, that means diuretic, potassium, and making maybe a small dose of lisinopril and not Entresto at this point. Jesse will get them there. I'll guarantee you that.
Mariah, you also are working with patients who are on this quad therapy, and these are complicated medications to manage, and patients that, as we've been talking about, with a lot of barriers. What tools do you use as you are doing your assessment with patients and then helping them to get access to these medications?
Yeah, we're really lucky. We've worked really hard, particularly in the reduced ejection fraction population, to allow copay-free access to all of these medications for our members. That takes some special programs on our part for our Medicare line of business, but for Medicaid, those medications have been consistently no copay, as all medications are on the Oregon Health Plan. Yeah, it's a really big barrier. And, you know, when in years past, Medicare has some rules in place that limit the ability of health plans to reduce copays. So, you know, people were having $3, $4, $5 copays for prescriptions like Entresto monthly, which was a huge barrier for our members. So we've put in place some special programs at Care Oregon with our dual eligible members to make those medications copay free and to really open up the formulary to make sure that our members have access. As those patients are discharging from the hospital on 4 medications or sometimes 3 or whatever, you know, whatever the inpatient team feels like they can manage, my team really tries to take over and connect those patients with some additional resources as the members are agreeable to connect with us. So sometimes that's around pill minders, so pill boxes, you know, recommending to maybe PCPs or prescribers that are taking over on an outpatient basis to consolidate medication regimens to something that's more simple. Especially, we're following these members for a minimum of 30 days. And I think a lot of people feel really motivated initially post-discharge, but that motivation can kind of trend down over the course of the 30 or 60 days post-hospitalization. So we try to prioritize connection with the outpatient team and then prioritize a medication regimen that we can recommend that we think that they can be adherent to. We can also do things with pill packing to allow for little pill packs to have everything you need that's morning and night to try to reduce the number of pill bottles, especially people that are houseless or trying to manage in the out in the world. You start talking about 5, 6 pill bottles. That's a lot of stuff to try to keep if you're living in only a backpack. So we can also do limited day supplies where patients can reconnect with their pharmacies. Old Town Clinic is a great example of a partner we use all the time, where they do weekly dispensing for our members and are really able to connect and have a touch point with our membership on a weekly basis, which has been, I think, really helpful in maintaining engagement.
That's great, Mariah. It sounds like some real big wins and we've come a long way in our ability to support patients who are really suffering with many of these social determinants of health. I'm so thankful that you mentioned the Old Town Clinic, because I know many of us who are logged in here are very familiar with that resource. And this is a question for anybody who wants to respond. What about RCP? Does somebody want to describe the resources that are available through RCP and tell us a little bit about what RCP is?
Go, Jane.
See, I was going to point my finger to Laura because I felt like she could articulate it so well.
Boy, anyone on the panel.
Laura.
Yeah, I'm trying to unmute again. Hold on. I'm sorry, I'm having difficulty unmuting. I was clicking and clicking. Well, let's see. Well, I don't know where to start here to kick off this question. It's a wonderful resource in the community, a wonderful partner that we have that provides medical respite for our houseless patients. I think any opportunities that we have to sort of replicate that model of care or expand on that model of care or sort of expand in our partnerships is absolutely needed. I think one of the efforts that we've made here at OHSU to sort of support our patients with heart failure was building that collaboration with RCP, specifically working with Jane with the resources within RCP, the nursing supports to just do that, to mitigate barriers for patients, to, adjust guideline directed medication treatments so that, we are, providing the most effective therapeutic treatment without burdening patients with things that just don't seem practical. I think, anything that we can do that is sort of reducing the number of barriers that our patients are facing, I think is our responsibility as both healthcare providers, as caring community members. And so, Jane, I don't know if you want to expand on what your thoughts are.
Great job. So I think what it did, at least for me, was it taught me all the things that you think somebody should be able to do. And then you go and you see what they're living and you're like, oh, okay. So you know what? I don't really care if you eat any salt at all. That's totally fine. I got you covered. And do you think you can take your meds once a day? So it really makes you understand what their story is. I think that's the most important thing. And also the providers that are there are just amazing and phenomenal, and they have really good support. So my applauding them right now. Yeah,
indeed. Well, thank you so much for sharing a little bit about that resource. I know that we were talking about community resources. There are never enough of them, and wanted to make sure that we mention RCP as well. We are just at time.
Actually, Anthony, there was somebody did also put in a plug for the advanced illness team, which is we work with the advanced team. I think they're called ACE, right?
Wonderful resource.
We work with them a lot. Again, these are people who specialize in listening to the patient's story and understanding how to reach them and what the best way to take care of, to help them manage their care, I guess.
Really
I think
great.
What's unique to both of them is they're innovative, our takeaway is how can we continue to think innovatively? How can we utilize and leverage our community partners? How can we problem solve together?
I love that.
Great. I do too. What a great way to close the panel. Thank you so much, Avery and Albert and Nathan, Jesse, Mariah, Karen, and Jane. You have been wonderful today. I'm going to hand it back over to Nick at the American Heart Association, who will close us out. And thank you all for joining us today.
Thank you, Anthony. Wow, proof there, a robust conversation. We like to stick to the time for the sake of everybody's busy schedule, but clearly there's a lot more to be discussed here. So I just want to end us with a special thank you to all of our presenters for the incredible information you've given us today. When I think about addressing racial disparities in heart failure care, I'm going to think about a lot of these powerful stories and anecdotes that are a part of your practices to deliver that quality care in so many different settings. Thank you, Dr. Camacho. Thank you, Laura, Mariah, Karen, Jesse, Jane, Nathan, and Anthony, for all your contributions. And we hope, everybody who's joined us today, that our presentation has provided you with helpful information on heart failure management. And sincerely thank you for taking time out of your busy schedule to join us. We will be sending a link to the recording and resources, as well as instructions to redeem your CME credits to all registered attendees. Everybody who's registered will receive that. And on behalf of the American Heart Association and OHSU, we'd like to thank you for attending today. Please take care.